Hello, welcome to the Healthful Woman Podcast, the fastest growing podcast in women's health. Today's Monday, June 10th, 2024. Today, I'm joined again by Dr. Lucky Sekhon, who is a reproductive endocrinologist and fertility specialist at RMA of New York, and a social media sensation. For more about Lucky, you can check out her website and blog, theluckyegg.com. Today, Lucky and I are going to do a Mailbag podcast, all questions related to fertility. Our questions today come from our awesome listeners, Masha, Bria, an anonymous listener, Colleen, Michelle, Brielle, and Alyssa. And we're going to be talking about alcohol and fertility, improved fertility after having a pregnancy, fibroids, irregular bleeding after a Mirena IUD, methotrexate for an ectopic pregnancy, and preserving fertility. Great topics, great questions. All right. Few reminders. The Unexpected, the book I wrote with Emily Astor, is available wherever you buy books. Second, please do email us any questions you have for our Mailbag podcast, like today's. To send in questions, you can email us directly, hw@healthfulwoman.com, or you can go to our website, www.healthfulwoman.com, and click on the link that says, send us your questions. I've been recording a bunch of Mailbag podcasts, so we have a lot coming up over the summer. Please remember, these questions you're sending in are for Mailbag podcasts, not your own personal medical advice that you need answered quickly. When I get questions like that, I feel bad because I'm not able to answer them in the time that you need them. If you do have a question about your own health for which you need an answer quickly, ask your doctor. All right, everyone, thanks for listening. See y'all next week. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. All right, I'm joined again by Dr. Lucky Sekhon. Lucky, my friend, my colleague, fertility specialist to the stars. Thank you so much for coming back to talk to me and to us and to answer our listener questions from the mailbag.
I love a good Q&A. Thank you for having me.
This is great. We're going to do rapid fire here. I'm just going to throw these at you like 100 miles an hour, and we're going to see, how you do, and I'll pepper you maybe with some follow-up questions. So our first question comes from Masha. Hi. Thank you so much for your most amazing and informative podcast. That was for me, by the way, lucky enough for you. I have a question that you can hopefully answer in the next Mailbag podcast. My friends and I wanted to know if there's any research between alcohol use and negative fertility outcomes when a woman is not yet planning pregnancy, but may try to conceive in the coming months. Does drinking alcohol in safe amounts affect a woman's fertility?
Yes, this is a great question. And I get asked this often, whether people are trying on their own or navigating treatment. I always say we don't have to be extreme about anything. I do think that it is okay to have a drink here or there, but really when you look at the large collection of studies which have tried to relate certain lifestyle patterns and behaviors to fertility outcomes, the suggestion is to keep your intake less than 4 drinks in a given week. So when I ask patients their history and, about their habits and their lifestyle, it's funny because everyone has a different definition of what's a lot of drinking or what's an acceptable or moderate amount. So I think saying 4 drinks in a given week is, kind of the guidance that I give, and it's based on evidence. I always tell patients it's a hard thing to study because a lot of behaviors go together. People that drink 20 drinks a week might also be more prone to be also people that smoke. So it's hard to kind of tease apart and study in a vacuum, but that's my guidance.
All right. I like that. 4 drinks a week. Good stuff. All right. Our next question is actually the same question from 2 listeners. I'm going to read them both. The first is from Bria, and the second is from an anonymous listener. From Bria. My husband and I tried to conceive for 2 years without any pregnancies before doing a round of IVF. Our first embryo transfer was successful, but sadly, we lost the pregnancy at 8 weeks. After my HCG levels returned to near zero, we started casually trying again while we waited for a follow-up appointment with our fertility clinic. To our shock, a month after my miscarriage, I was pregnant naturally. After 2 years of trying without success, we thought we had pretty slim chances of ever getting pregnant naturally. Lots of people say that women are very fertile after a miscarriage. Is this just a myth, or is there any truth to it? And the second question, which is very similar. Hi, I'm obsessed with this podcast. I'm a nurse who's hoping to work in women's health one day. So I find all these topics fascinating. I was wondering if you would be able to speak on getting pregnant naturally after going through fertility treatment. I struggled to get pregnant and have been through 2 failed IUIs and end up going through IVF. Thank God I had a baby almost 4 months ago, and my OB told me that my odds of getting pregnant naturally are much higher postpartum. Am I technically more fertile now? Can you shed some light on the data and how it works? Thanks so much. So basically, are you more fertile after a miscarriage? Are you more fertile after a birth? And particularly for people who had trouble getting pregnant for those kinds of pregnancies.
Yes, I get asked this all the time. I guess the question or the assumption here is that there's some sort of priming, like being pregnant, the act of carrying the pregnancy, even if it resulted in miscarriage or whether you had a live birth, that it changes your body somehow. It like sets your uterus up for success. And I think there is some sort of association there, but it's different than what a lot of people are assuming or thinking. It's not so much that I think that the pregnancy is priming you to be more fertile in the next attempt. I think statistically, anyone who's had a miscarriage, something that I tell them to encourage them is that statistically, I think of them as being in a different category than someone who's never been able to get pregnant. Right. It means it shows me that the machinery did work to a point, right? Your tubes were open. There was a way for the sperm and the egg to meet. There was a way for that embryo to implant. Why it stopped growing and didn't progress to a live birth could be a completely unrelated issue, but at least we know a lot of it worked. So when we look at our data, we see that women who've had prior miscarriages tend to have a higher overall fertility rate. But I think it's just because you're looking at a different population versus someone who's been trying years on end and has never once had a pregnancy. Those are kind of 2 different populations. I think, for the anonymous listener who asked the question, if she has frozen embryos from that original IVF cycle, then I don't think it's wrong to just say, you know what, I'm ready for baby number 2. I'm just going to go ahead and use one of my frozen embryos because I struggled for this long and I went through this process and this is the purpose of why we froze them. But it's not wrong for her to try. Right. She could try for 3 to 6 months and then say, okay, backup plan, I'm going to use one of my frozen embryos. I think it depends on how many embryos she has, because I would be concerned about the timeline. I'm always thinking about, where are we landing in terms of the number of eggs you're going to have in case you need to do another retrieval, and your egg quality in case you need to do another egg retrieval. So would I say try for years on end and then go back to use 1 or 2 embryos? No, I don't think that's a good strategy, because I kind of want to know sooner rather than later if those embryos are going to be useful and helpful to us.
Right. It's so interesting because all of us, certainly people just know people, and certainly those of us who take care of, pregnant people all the time, we all have had the story of someone that years and years of infertility, they do IVF, they have a baby, and we're like, are you going to do birth control afterwards? Like, no, what are you, crazy? I'm infertile. And then like 3 months later, they're pregnant again. Like, what the hell? And so there have always been like 3 theories. The first you mentioned, which is it somehow like it changes your body. Like physiologically, your uterus is better, whatever, something's better, which I don't really understand, but okay. The second is what you said that, well, no, you are now a person who's had a baby. So it's like a natural selection type of thing. You're better. But the third that people talk about is this undiscovered sort of nebulous psychological factor. That like somehow people, that there's all this stress and commotion and fear and anger and anxiety. Yeah. And now that you've had your baby, that sort of is all like released from your wah.
I've never actually thought of that, and I've never heard someone say that.
That's before. So interesting, because I was that was like the first thing that people would say to me, like, that people said, well, since I've had a baby, I no longer have, the
major
part,
fear,
right? The part of fertility that we don't understand, right? Which is somehow, again, whether you call this blaming the mother or whether it's just something deep that we don't get, that sort of that spiritual / psychological / emotional component to pregnancy that somehow your inner sense and your being relaxes and you get pregnant. So I was like, I don't know. I mean, maybe like it's not implausible, right? Obviously, because there can be a component of how our mental health affects our physical health. But those are the 3 theories. So you're more in line with theory 2.
I'm more in line with theory 2, although I will say this is an anecdotal case, but I did have a patient who had years and years from an eating disorder, not ovulating, and had a super paper thin lining that just never got thick. And we ended up doing a transfer with a very thin lining, and it worked, and that was great. And then when she came back for baby number 2, her lining was beautifully thick and responded well. And that to me makes a little bit of sense.
Maybe number 1. Yeah.
Maybe the uterus in that case did actually get primed, because I think the reason it was thin was because of such long-term estrogen deprivation.
Right.
And so I do think that, there are times where maybe the priming thing makes sense. I also, I feel like people don't realize how illogical our reproductive system can be.
Right.
Because all of those explanations are logical. But when you think about what could have happened, especially, for example, when patients come to me and they're like, listen, I'm 40, I'm going through infertility, don't understand because my mom had me at 43, so I thought I was going to be super fertile. And I explained to them, I don't know what cosmic forces lined up in the universe that your mom happened to ovulate a healthy egg where there was a lot of unhealthy eggs at that age, probably. And everything lined up perfectly, but that can happen to anyone. Like there's that serendipity and chance element that's not logical, and you can't put your finger on it. But that's also something that's at play as well. I mean,
it's similar. If you go back, like, let's say you have a couple that's younger, and why did they have 2 years of infertility?
Right.
And so it could be, unexplained infertility. We don't know why. You try this, try that. It could have just been they're the outliers who had really bad luck, right?
Exactly.
Someone's going to have really bad luck, right? Yeah. Someone's going to have really good luck, and someone's going to have really bad luck. Yeah. And so it's possible that there never was a quote unquote problem.
Yeah.
Just the odds didn't fall in their favor. They're the ones that lost all the money at blackjack, you know, and then you come back the next day and you win all the money. And there is such an element to that with fertility. Yeah. It doesn't mean you shouldn't do workups and do the right tests. Like, obviously you have to do you got to do it right. But some of it's that's just all it is.
Another example is, a patient who in her early 30s came to me, ended up getting like 10 embryos from her IVF cycle, but only 1 was normal out of the 10.
Right.
And we did specialized testing. I did karyotypes because I'm like, maybe they've got something going on.
Right.
Nothing came up. And they did another round, had a similar number of embryos, and like 8 out of 10 were normal. Yeah. So what people, who aren't maybe familiar with biostatistics need to understand is that when you have a random collection of eggs randomly recruited in that cycle, that's not necessarily going to be representative of what's going on with all of your eggs.
Right.
And so there's all of this randomness and skew of the statistics you were expecting. But eventually when your numbers get high enough, we get something called regression to the mean.
Right.
Right. Eventually things will start to make sense for most people.
Right. All right. Great. Next question from Michelle. Hi. Yes, I also found you through the toast. Are you familiar with the toast?
No.
Oh my God. Because you're not a millennial, right?
I don't know what I am because I was born to immigrant parents. Sometimes I feel like I'm a boomer. I have no idea what's going on.
So our listeners know this. The Toast is a very popular podcast amongst the millennials.
Okay.
And God bless them. Yeah. And I delivered Jackie, who's one of the Toasters' babies. And so I was on that podcast.
Oh, cool.
And so now, God bless, we love the Toasters. Many of them have jumped on to our train. So when you hear this in the question, that's what it is.
I'm going to have to take a listen. And honestly, I'm trying to become very Gen Z because that's where it's at right now.
So. Yeah, you've already, in the last podcast, dropped a couple of like pop culture references. You mentioned a Kardashian. I don't know which one you did, but whatever. So you would definitely be on board with this because they're all pop culture and they're really, really funny. All right. Here we go. Hi. Yes, I also found you through the Toast, and I'm so happy I did. Such an informative and easy podcast to listen to. Everything is talked about in such a calm and understanding way. By the way, I only read this to like make me sound good. It has nothing to do with the
compliments.
Yeah, nothing to do with this. Well, they will. They'll send in others. All right. My question is, now that Nate's done complimenting himself, my question is, I removed the Mirena IUD. I actually hope you had a doctor remove it. Michelle, if you removed it yourself, then all the power to you. But
that's talent.
Yeah, let's assume that's what you meant. All right. I removed the Mirena IUD about 6 months ago, and I can tell my hormones are not fully back to a settled place. Example, spotting after period for days. I was told this happens because of uneven hormones. Would it be a mistake to try and conceive at this time? My OB had told me to wait 6 months to try to be safe. Thank you. So there's 2 questions here. 1, is there a problem with quote unquote her hormones? Mm-hmm. And 2, is it a mistake to try to conceive after your IUD comes out?
Okay. So the IUD is an immediately reversible form of contraception. So when you pull the IUD, when you have someone else remove it.
Yeah, preferably a doctor or a midwife or someone.
Insert disclaimer here.
Yeah.
you should assume that you're going to be able to get pregnant right then and there. And I mention that because a lot of times people will say, maybe I need to stop this form of birth control and give myself like 3 to 6 months to warm up.
Like a washout.
Expect that you might get pregnant right away. That could happen.
Right.
And I don't think it's a problem.
I don't know what I don't know who your OB is or whether they actually said this or meant to say this. But if they said it, that's not typical. Typically, we don't tell people to wait after night. We tell them, go have sex tonight. Like whatever. If it works, it works.
Yeah.
But there's no danger to it in that sense.
I don't think there's necessarily something dangerous if you conceive while having this history of irregular spotting through your cycle. However, since you know about it and you're noting it and you're not pregnant yet, I think you should get it investigated. And it's usually one of two things when I hear this type of history. The most common thing is there's something going on inside your uterine lining. And the most common thing would be a polyp, which is essentially like a skin tag. A lot of us get polyps and they come and go and they can break down with your period. Sometimes they're bigger and they're going to be more persistent, but they're really vascular. They have a lot of blood flow and they can cause a lot of pesky spotting throughout the cycle, especially after you ovulate because of the hormonal changes. So an easy test that you can do is a saline sonogram, or just even start with a basic sonogram. But the best thing to do is a saline sonogram because you really have this collapsed cavity. That's what the uterus is. And it's like, imagine, two edges of a shag rug against each other. It's easy for things to hide in there. So you want to inflate the uterine cavity with fluid in a saline sonogram, and you're going to be able to see whether the cavity has a nice smooth contour or do you have things jutting into it like a polyp or even a fibroid. And if you have those, it makes sense, I think, to get them removed in a really simple procedure called hysteroscopy, because it's going to create a better environment for an embryo to implant. And, the uterus doesn't like blood, so it's just better to not have that as a factor. Now, if you do the test and everything is normal structurally, it is true there are certain hormonal changes or imbalances that can make you predisposed to your progesterone level fluctuating after you ovulate and that causing this irregular spotting. That's less common, but things to look out for are thyroid function. So get your thyroid checked, and a hormone called prolactin. All of that can interfere with the signals that your brain are sending to your ovary.
If she has one of those, it was not because she had the Mirena IUD.
Correct.
Right.
Correct.
It's just coincidentally.
Well, the Mirena usually stops you from bleeding.
Right. Exactly.
So that's like one of the treatments for what we call dysfunctional uterine bleeding.
Right.
And so if anything, it was probably keeping these symptoms at bay.
Right. We talked about this in the last podcast specific to pills, but it's the same with the Mirena. If someone gets their Mirena out and then they have irregular bleeding, it's very unlikely because they had the Mirena in.
Yes.
It's just this would have happened otherwise, but the Mirena was sort of preventing it from happening in a therapeutic way. Okay, good stuff. All right, next question is going to be from Brielle. All right. Hi, Dr. Fox. I came across your show not too long ago and have genuinely enjoyed each episode I've listened to. I apologize. See how I do this? I apologize in advance for the lengthy question. Hey, do not apologize for lengthy questions. I could always edit them. I suffered an ectopic pregnancy that was treated with 2 doses of methotrexate. This was my second pregnancy. My first was totally healthy and uncomplicated and resulted in the birth of my daughter, who's now 21 months old. I was told I need to wait 3 to 6 months post-methotrexate to conceive again. It seems that this advice varies from doctor to doctor, and I cannot find any evidence to support such a long wait when methotrexate is used in such small doses for the treatment of an ectopic pregnancy. I would be inclined to wait the full recommended time. However, my husband has now had 2 vasectomy reversals as he is prone to scarring. Long story is why that was necessary, which I won't go into. I'm worried that if I wait another 2 months, we will be dealing with male factor infertility and I'll have no choice but to do IVF. Would you recommend waiting despite my complicated circumstance? And the second part, in hindsight, I wish I had just done surgery, but as you know, these decisions are often made quickly, as waiting a day to think things through is rarely an option. I appreciate your insight. So I'm going to break that down for you. Question number 1 is related to, in general, should someone wait that long after methotrexate before conceiving? Hard to get very specific into Brielle's own circumstances because we don't exactly know the male factor here.
Yeah.
And then question 2 is, okay, when you're seeing someone with an ectopic and you're counseling them about methotrexate versus surgery, how do you take into account future fertility with that decision? Obviously, there's pluses and minuses to surgery. If there's medication, it'll work. You have surgery. We've got a podcast on that, but specific to fertility. So first question, how long do you tell people to wait after methotrexate?
3 months.
Yeah. And it's it's a pretty hard line on that
Yeah.
because
I've never said 6 months.
Yeah. I mean, the fear is that methotrexate really causes birth defects.
Yeah.
It's not like one of the medications that might,
Yeah.
maybe, like it's bad, right?
Yeah.
You do not want to be on methotrexate when you conceive. And how long does it take to get out of your system? It's probably at least a month. And so we put a buffer on that and say
Right.
2 to like 3 months. And so that's a pretty standard recommendation. So I would not recommend trying to get pregnant within 3 months of methotrexate. That doesn't mean there will be a problem if you do get pregnant on your own or whatever, but I would not intend to get pregnant after methotrexate.
A lot of fertility clinics allow patients to start preparing for an embryo transfer, maybe, 3 weeks into that 3-month wait at the tail end, as long as they know the transfer is happening outside of that 90-day window.
Yeah. Okay. So the second question, which I think is the bigger one. So obviously you see people with ectopic pregnancies and you're deciding give her methotrexate versus doing the salpingectomy to remove the tube surgically.
Yes.
Aside from the general medical / surgical risk benefits, how much do you get into the fertility aspect of it?
Well, I pride myself on being very proactive and on top of ectopics. We always say at our clinic, it's seldom that you'll ever have a patient with a rupture ectopic in the middle of the night because we pick them up early from doing diagnostic imaging, sometimes sending them your way for diagnostic imaging, and follow their HCG or pregnancy hormone levels. So we can kind of see from a very early stage, this is a pregnancy that's suspicious. We can't see where it is, but it's behaving like an ectopic pregnancy would with, an oscillating HCG level. So sometimes the choice is not available because we don't actually see it, right? And I'll explain what I mean when I say that. Let's say I have someone with an abnormally rising HCG level, and I know this is not a normal pregnancy at this point. We've given it multiple data points, and we know that it's not tracking normally. I don't reflexively just say, let's just give you methotrexate because I think this could be an ectopic. A lot of times I will do things like a very gentle DNC where we bring them in, we sedate the patient with similar sedation to what's given during an egg retrieval. It takes about 5 to 10 minutes. And we just basically will kind of disrupt the lining. Because if the lining's thick, a lot of these are early abnormal pregnancies inside the uterus. So I might disrupt the lining a little bit. And that way the thought is if there's an early abnormal pregnancy inside the uterus, it's not in the tubes, it's not an ectopic, and the HCG level goes down tomorrow because I've disrupted that process that was happening in the uterus, because it's kind of like trying to persist, but it's not doing so successfully, then I know that this patient doesn't need methotrexate. Let's say the levels continue to rise the next day. Well, that's a situation where I would offer the methotrexate because I would say, I've now proven that even despite disrupting anything going on in the uterine cavity, something is continuing to grow. And where else could it be? It's an ectopic. So in those situations, I'm not going to offer surgery to the patient because I wouldn't know what to take out, right? I can't tell. Is it in the left tube? Is it in the right tube? Where is this? So the only option at that point, if you're trying to nip it in the bud, is let's give methotrexate. And studies have shown if you give methotrexate earlier, it has a better chance of working, right?
Right.
So those are situations where the choice is obvious. And what I tell patients is they need to wait 3 months. And this is not from time of resolution where the levels are now negative, but from the time that the methotrexate is administered, and we monitor for that first week. We check, 4 days later, 7 days later. And as long as there's at least a 15% drop in that level between day 4 and day 7, then you're considered treated. Otherwise, you're giving another dose sometimes, as this listener had to have. And then you're just kind of keeping track of the levels every 1 to 2 weeks once you're successfully treated and making sure it resolves completely. Patients can still have a ruptured tube, even though they got the methotrexate. So that's something I always tell patients. I might be giving you this 90-day wait that you've now bought into, and you might still end up needing surgery. So you have to be okay with that. And let's say you do see it on the ultrasound. Now, this is when I talk to patients about, you have the option of doing the methotrexate, or we can surgically remove the tube. Now, obviously, I don't take surgery lightly, but the surgery that's done for, especially in a non-emergent setting where the person's not bleeding.
It's pretty low risk.
It's very low risk. And, if they have a sense of urgency, it might be nice to just take care of this definitively. And that way they can just kind of get back on the path to fertility treatment right away. Obviously, there's going to be a little bit of downtime, but it's a minimally invasive approach. And, sometimes having this ectopic, it's damaging to the tube. So the nice thing about just removing the tube is now it's no longer communicating with the uterine cavity, because having tubal damage can actually interfere with the uterine cavity environment and make an embryo less likely to implant or more likely to miscarry. So after I've treated someone with methotrexate successfully, I usually send them for an HSG because I want to examine the tube. And a lot of times it's great. You know, the methotrexate did a good job. It dissolved the ectopic and there isn't any residual scarring or issues. But once in a while, I'll find that there is a tubal issue. And maybe that was the underlying risk factor for why this happened. And it just wasn't picked up previously.
Yeah.
So those are kind of the different things I think about. It really depends on the situation.
Yeah.
And I don't think 3 months is that detrimental to someone's fertility. And that's something important. Obviously, she has a different situation with vasectomy. And maybe as a side note, I would consider whether he should freeze a few vials of sperm. So that way you have other options as well.
Yeah. I agree that when it's very early, there really isn't an option for surgery because you don't know what you're taking out.
Right.
That it comes up when we see the ectopic and we're trying to decide, and someone's like, well, if I remove the tube, won't that reduce my fertility? But I always tell people, sort of again, as not a lay person, but not as a fertility specialist, I say potentially, obviously, you'd rather have 2 tubes than 1 tube. But the question is, you had an ectopic in this tube.
Yeah.
So number one, why? It could have been from an underlying tubal problem, in which case we can fix it, but maybe you'll get another ectopic there. Or like you said, it could be toxic. And number 2, the ectopic itself could have damaged the tube.
Yes.
And so it's not necessarily better to have an ectopic relieved by methotrexate than by surgery. It might be better, it might be worse. And it's really hard to know for sure from a fertility perspective which way you're better off. And again, if you pick them up very early, you're going to do methotrexate because before that even happens.
Yep. And your fallopian tubes do not produce hormones.
Right.
They're just a conduit, a place for the sperm and the egg to meet. And by the way, a lot of people think that you ovulate 1 month on the left, 1 month on the right. And so automatically this detracts from your chances by 50%. That's not true. You ovulate randomly. Sometimes it could be 3 times from one side and then 2 times from the other. And you can have what we call contralateral transfer of an egg to the opposite tube.
It flips over. Because
the tubes aren't like what you see in a diagram. They're not out like a T shape. They're actually hanging out kind of dependent, like down by both of the ovaries, which often are right next to each other behind the uterus. They kind of move around a little bit. So there is an ability to ovulate from one side where there isn't a tube and for it to be picked up by the opposite side too.
We definitely see that because on ultrasound, when someone's pregnant, you can see which ovary the egg came from, typically the corpus luteum. And sometimes we know someone had their left tube removed, for example. And we see that on the left side. You're like, whoa, like you got pregnant from the, the side that doesn't have a tube. And so, it absolutely does happen.
It will diminish your overall success by a little bit, but definitely not by 50%.
All right, cool. All right, next question is about fibroids. Colleen sent in this question. It's a pretty long question. And Colleen, it's specific to her, but I want to sort of summarize it by basically saying the question as follows. Lucky, how do you counsel women about fibroids prior to pregnancy? Meaning, if you see it, because there's fibroids, a lot of women have them. There are a lot of different locations. Are there certain fibroids that you say, this needs to be removed automatically, meaning before you even start trying? That's sort of category A. Category B is, this is a fibroid that we're going to watch. We'll see how you do. And if you have problems conceiving or miscarrying, I'll remove it. And category number 3 is, under no circumstances are removing this fibroid. That's crazy talk. It has nothing to do with this.
Right. So when you think of the uterus, it's a big, thick muscle, right? And it has an inner lining. That's the cavity where the embryo is going to implant. And that's what builds up and sheds every time you get a period. Then you have kind of the wall, which is all muscle. And then you have like the surface of that muscular layer. And so that's like on the outskirts of the uterus. And so if you ever look up what fibroids look like in a diagram, you'll see them labeled according to where they're located in the cavity. The ones that are in the inner lining that kind of jut into the cavity, and they're very obvious when you do tests like a saline sonogram, those are called submucosal fibroids. And in general, I would say they're taking up valuable real estate. And even if they're small, like 1 centimeter, I will in general recommend removal.
So they're like the squatters in New York City. This is those fibroids. So you're on the side of removal. All right, there we go.
I feel
politically, for fibroids, Lucky's get the squatters out.
Yes.
All right.
I think that having said that, people will have these submucosal fibroids and be able to get pregnant.
Sure.
But there is a potential risk for miscarriage, right? Because sometimes that fibroid could encroach upon the space that embryo and eventual fetus needs to grow and expand. And it can cause issues with even like the placenta and how it implants. So not to scare anyone, but definitely it's something that usually I will say to remove.
Right.
If it's intramural, meaning it's in that thick muscle wall, let's say you have like a 2 centimeter, it's not jutting into the cavity. It's not, you didn't even know you had it. 40 to 80%, which is a garbage statistic, by the way, depends on which population you're looking at. But 40 to 80% of women have fibroids. They're super common. A lot of people listening on this right now have fibroids and have no idea about it. I can guarantee it. And if it's not causing heavy periods or pain because they're large enough that they're pressing on your bladder or your bowel, then they're not an issue. And someone with like a 2-3 centimeter fibroid that's in the muscle wall of the uterus and it's not bothering anyone, I would never say go have surgery and have someone make an incision on your uterus to remove this. It's not affecting anything. But if it's larger and there's multiple, let's say you have over 5 centimeter size fibroids and there's many of them and like they're kind of taking up a lot of the bulk of the uterus, which is that big, thick muscle, that could reroute blood flow from the inner lining. That can just create an overall environment that's not as conducive to fertility. And it can cause problems, as you know, during pregnancy because there's rapid growth of the uterus. And fibroids have a lot of blood supply, and a fibroid could outgrow its blood supply because of the changes that happen during pregnancy with the way the uterus grows. And people come in with pain. It's almost like your fibroid is experiencing like a heart attack, and it can cause things like contractions, preterm labor. So, if I think someone has enough fibroids that are large enough that they could be at risk of degeneration during pregnancy or that they are struggling and it's hard for them to get pregnant, it might be something to consider. If they're having really heavy periods and bulk symptoms where it's like pushing on the bladder every time, they're having constipation when they're trying to go to the bathroom, those are issues that I would rather you rectify before getting pregnant and having a large uterus in the mix as well, right? If it's on the outskirts, it's called a subserosal. It's like on the surface of the uterus. I'm not so worried about those, but again, it depends. Are they so big that they're pushing on other vital structures or organs? So you kind of have to look at the whole picture. But it's really those submucosal ones or intramural in the muscle wall. If there's many of them and they're kind of pushing on the cavity anyway, even though they're not inside the cavity, those are the ones that I usually recommend removing. And I'll add, if someone comes to me even for egg freezing, but I can't get to their ovaries because the fibroid is in the way and I can't even see an ovary on one side, how am I going to retrieve eggs from that ovary? I've had patients because they're like, I am symptomatic anyway. Now's the time to get the surgery because then after that I can have my egg retrieval.
Right. Yeah, no, listen, it's a tough question because it's so individualized because also many times when we do the surgery, not for the ones that jut into the cavity, but the ones on the outside, if you do the surgery, take them out, they now need C-sections for their deliveries. And so, okay, it's not the end of the world, but it's a big deal, right? Now your deliveries are going to be different. And so it's always sort of again, unlike when we're talking about ectopics where the surgery is very straightforward, when you take out fibroids, the surgery may or may not be straightforward, but it has more repercussions afterwards. So it's part of the equation, but it really has to be individualized in that sense. All right. Last question from Alyssa. Hi, Dr. Fox. Firstly, a huge thank you for all that you have done in creating such a high quality resource for women's health education. But I didn't make this up. This is people actually wrote this to me.
No, listen, I listened to your podcast, so I second all of these comments.
All right. God bless. It's going to get better at the end. It's been immensely valuable to me and so many others. Now for my question. It begs, like, why didn't I cut out the beginning? Because I don't want to. All right. Now for my question. I'm a 26-year-old woman who is planning on delaying pregnancy until about the age of 33. For career reasons, but it's very precise.
I know.
I like that.
I like her personality.
That's someone who had like one of those planners when I was in middle school that we called them, what were they called? Chandlers?
Agendas?
I don't know what they were called. Like the little black books that have like every single day. This is pre-phones. All right. Back to your question. Is there anything I can do to evaluate my fertility now? We talked a lot about this in the last podcast. So I could perhaps pursue fertility preserving methods such as egg freezing. I've had chlamydia before, so I'm concerned that my tubes may be blocked. If I would need to do IVF for that future anyways, my thought is that I may as well freeze eggs now. I'm also worried about diminished ovarian reserve / poor egg quality. Additionally, I have PCOS. Thank you again. You're the GOAT. Thank you for that. So I guess the main question is, all right, you have someone who's young and healthy.
Yes.
Right. And she knows that she's going to be waiting X amount of years. At what point when you see them, do you say, you know what, it makes a lot of sense to freeze your eggs now versus let's check in again when you are closer to 33? Like, how would you handle sort of that specific scenario?
I mean, this is clearly a forward-thinking individual who
Great.
wants to plan everything out.
We love it.
Right? And I always say there's no downside to doing egg freezing for fertility preservation. My job is to be conservative. So I'm never going to be the person that says, you don't need to do this. Right? Especially if someone is going to find themselves in their mid-30s and beyond trying to build their family. To me, then the answer is always going to be, yes, I recommend freezing something, just because of what we know about when egg quality starts to change a little bit more rapidly, right? Your fertility doesn't fall off a cliff at age 35, but you do see a much higher rate of having eggs turn into abnormal embryos that are missing or have extra DNA, right? That don't have the ability to turn into a healthy pregnancy. Everyone still has normal eggs, when they're in their 40s, but it starts to become harder to ovulate that healthy egg naturally on your own. And even in your early 30s, I would say if I was to take all the eggs out of your ovaries and fertilize them with sperm and turn them into embryos, I would expect about a third of them to have those errors.
Right.
And when it was as good as it gets in your 20s, it was like 20 to 25%. So no one makes perfect embryos from their eggs. That's the first thing to know. And the rate at which you have eggs being released on a monthly basis that could give rise to an abnormal embryo increases much more sharply at 35. Like by the time you get to 38, you're looking at 50% in. And by the time you get to 40, 70% of embryos test abnormal, 30% are normal. So it almost increases just based on age alone. There's an increased risk of needing a little bit of assistance. I'm not saying everyone's going to need IVF, but it just might take longer. It will be a little less efficient, right? And so having a store of eggs from when you were younger, especially in your late 20s, when the conversion rate to a healthy embryo is much higher, and you're probably going to have access to a lot more in a given egg retrieval now versus what's available later down the line, because the number that get recruited, it's almost like a rationing.
Right.
It's going to reflect how many you have stored up in the vault, in the ovary, right? So you're just giving yourself a head start if and should you ever run into problems. And I think it's not just about age. Anyone who has any sort of gynecologic condition, she mentioned PCOS, that puts you at a slightly higher chance of needing a little bit of assistance or intervention. And that means it could mean, getting you to ovulate regularly with medications and helping you track your cycle. But after a certain point, that's going to get old. And you might say after 6 months of doing that, okay, let's just move on to IVF at this point, right? That's kind of like the next step or progression and the most effective and efficient treatment option that we have at our disposal right now. So you're essentially setting yourself up for future success if and should you ever need IVF. And to me, the main downside is the effort required, which is really, it's a 2-week process.
Right.
It's taking injectable medications. They're subcutaneous injections, meaning they're not scary long needles. It's pretty user-friendly, and most of my patients are able to do them on their own without issues. And then you're coming in for a procedure, which I wouldn't even call a surgery. It's a very minor procedure done vaginally while you're sleeping for 5 to 10 minutes to take the eggs out. And the recovery and downtime is very, very minimal. That's the one day that you take off. I think the effort and the time, and then also, of course, the cost. It's expensive.
Right.
That's the downside. If to you, that's not a downside because the company you work for has fertility benefits and this would be covered, to me, it's a no-brainer. You should do it. I think if you're paying out of pocket, unfortunately, as a physician, I don't want to be talking about money and costs, but we have to be practical and think.
Right.
So if someone comes to me and they're like, I'm 30, should I be freezing my eggs? But I'm in a relationship and we're going to start trying, by the end of the summer, and we only want one child. I'm like, well, then maybe just try and do that. But if they're like, I want to have 3 kids and I'm not ready to start until I'm 33, well, you're inevitably going to be in that over 35 zone where there's a higher chance of needing assistance. So why not have a backup plan?
Yeah, it always seemed to me that, again, the potential downside is time and effort, like I said, a few weeks, cost. And just so everyone knows, so much of the cost are the medications.
Yeah.
It's not like the doctors, right? It's really, the medications are extremely expensive, and that's not, that's just a pass through from the pharmacy essentially, but it is what it is. They are expensive. And I guess potentially some consternation later in life that I have these frozen eggs or frozen embryos and what do I do with them?
Right.
Right. Okay. Like there may be some, I wish I didn't have to make this quote unquote ethical decision if someone views it as an ethical decision or not, whatever. I'm adding that to the list. For a lot of people, it's not a downside, but for some it might be. But that's it really. It's not, it's not particularly dangerous procedure, as you said. And I guess it's unpleasant from a physical standpoint, but it's not, as things go,
Yes.
it's not quite as bad as other things we do in medicine to people.
I mean, I guess I can say this and you don't have to react, but I don't think I'm the best patient. I'm known to be anxious, and I'm very different as a patient than I am as a physician. And I went through the process, and I remember thinking to myself, "Wow, I actually am pleasantly surprised because I was expecting it to be worse for me. I hate needles. I hate being poked and prodded. It went by really quick, and obviously, I had the benefit of doing it where I work, and so maybe I was just more familiar, and that made it easier." But I did feel like it was shockingly easy compared to a lot of how it's portrayed and how people view it.
Yeah, cool. All right, Lucky, thank you so much for sticking around doing podcast number 2.
This was so fun.
Yeah, we're definitely going to have you back because you're awesome and this was great.
And then next time you can read the compliments about me.
Yeah, we're gonna hang on to those because you are the GOAT. Awesome. All right,
thank you so much.
Thank you for listening to the Healthful Woman Podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.